Thank you, Dr. Crony, for that introduction. So I'm Ariana, for those of you who don't know me, and along with Dana and Lianna, we're the leaders of SPACE. Thank you for coming today. We do not have any disclosures. So today we're going to spend most of the time talking to you about how we created a workshop and an OSCE for fourth-year students. We're also going to start by talking about health literacy in general and why it's important to have a health literacy component in a medical school curriculum. And then lastly, we'll touch on some of our other curricular changes that involve health literacy throughout the 4 years. So to start, what is SPACE? SPACE stands for Student as Patient and Community Educators. We're a student-established and run group, so we were started in 2009 by two then Mount Sinai medical students, Rachel and Allison, who recognized the need for health literacy within the curriculum. So they started the group to raise awareness about health literacy, and then throughout the years we've kind of added workshops and lectures to fulfill that need. As I said before, we have workshops across all 4 years, which you will hear more about a little later. So if everyone could just kind of take 10 seconds and try to read this or interpret this paragraph to yourself. It's okay if you don't have it. If someone could be brave and try to read it for us aloud. Yeah.
Just a lot of the words are backwards.
Well, some of them.
Your physician has recommended that you have a colonoscopy. Colonoscopy is a test for colon cancer. It involves inserting flexible viewing scope into your rectum. You must drink a special liquid the night before the examination to clean out your colon.
All right.
Yes, good job. So that was great. You actually did much better than most people when they try to read that for the first time. Generally, it takes people a little longer. But as you can kind of see, it's not that you can't read this paragraph. It just takes a little bit more time. It's hard, right? You have to spend time reading each individual word, and the overall message kind of gets lost, simulating what the experience might be like for someone with low health literacy when they're trying to read patient materials, right? They kind of get bogged down in the details, focusing on small things, and then the overall message of what's going on with them kind of goes out the window. So what is health literacy? The Institute of Medicine defines health literacy as the ability to obtain, process, and understand basic health information and services needed to make appropriate health decisions and follow instructions for treatment. So there's a lot in that definition, right? You have to obtain it, process, and understand. So it's not enough to just be able to find health information, but you then have to be able to integrate it, process it, and translate it into health-promoting behaviors. So where do most of us find our health information? Here. I'm constantly surprised when patients come into the office or even on visiting docs when we go into homes, no matter where the patient lives, they often pull out their iPhone 6, their iPads. They almost always have access to the internet. So for better or for worse, this is where we and most of our patients are obtaining our health information. Just because we can obtain health information does not mean that we can kind of fulfill the other requirements of the definition. So if you look at this graphic, right, 75% of adults have looked for health or medical information, and 60% of adults have searched for health information online. So pretty consistent with what we just said. That being said, more than 50% of adults, while have access to basic health information, cannot perform basic health tasks, like interpreting their child's vaccination chart, or reading their prescription label, right? A basic task that we take for granted every day. So we're going to use this little app called Pull Everywhere. So if you have a cell phone or even a computer or your iPad handy, if you go to that website, you see at the top where it says respond@pullev.com/DanaCasey433. Everyone could just go to that website. It'll give you the option to answer this question. What is the percentage of the American adult population that has proficient health literacy? And if anyone's having any problems, just let us know. Good. Someone figured it out. Good job.
This was determined how? The date? I mean, you're going to compare it to?
Yeah, I'll tell you on the next slide. Anyone else? Are we all good? Okay. One more? Yeah, so a wide range of guesses. So the percentage of the American adult population that has proficient health literacy is actually 12%. Good job, actually. So, and this data is from the Institute of Medicine, did a 2008 study on health literacy. Yeah, so also we wanted to talk a little bit about prose and quantitative literacy. So while 12% of adults have proficient health literacy, about half of adults have basic or below basic prose and quantitative literacy. And as you can imagine, kind of the combination of these literacies often contribute to patient misunderstanding and poor outcomes in health. So for example, a patient with diabetes, right? They might not only be able to not understand their prescription label, right, but if they also have poor quantitative literacy, it will be hard for them to keep track of their glucose level and measure their insulin. So it's the combination of these factors that often contribute to poor health. While working with patients, it's very important for us to remember that limited health literacy affects all patient groups. It affects adults of all ages, all races, of all educational backgrounds. That being said, there are distinct risk groups. So people of color, older adults, and people with poor health often struggle the most with finding and processing health information. There are some other risk factors associated with low health literacy, such as living in the South or Northeast, like where we live. Female sex, incarceration, and if you have an income status defined as poor or near poor. So just to show you kind of the human impact of health literacy, we just wanted to show this video clip that we show actually to the third-year medical students in one of our workshops.
The patients can be equally high.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
So pretty powerful. You could see kind of how this really affects patients' lives. Now that we've looked at it on an individual level, we wanted to speak a little bit more about the broader impact of health literacy. So in general, health literacy has a substantial impact and influence on health outcomes. As you can see on the slide, low health literacy has been associated with multiple adverse health outcomes, including higher rates of anxiety and depression, increased non-adherence, higher hospital readmission rates, and increased healthcare costs. All of these ultimately lead to poor health outcomes. Additionally, the literature has shown that patients are particularly vulnerable at times of transition, such as hospital discharge. So as you'll hear later, that's where we chose to focus the efforts for our OSCE. This graph shows the relationship between literacy level and all-cause mortality. As you can see, adults with limited literacy had a higher rate of mortality than adults with adequate literacy. So we just wanted to speak a little bit about the specifics of one study. So in 2004, the Agency for Healthcare Research and Quality did a report on literacy and health outcomes that was requested by the American Medical Association. So what they did was basically this large literature review of all the studies that have been done on health literacy and their association with health outcomes. Their main finding was that there is a relationship between low health literacy and poor health outcomes. And they also found a positive relationship between high health literacy and knowledge of preventive and basic health services, so like mammography and knowing how to interpret your emergency department discharge instructions. One type of relationship that the report looked at closely was the relationship between health literacy and smoking. The studies consistently showed a positive relationship between low health literacy and adult smokers. One study even showed a relationship between low health literacy and smoking amongst adolescents, which perhaps will guide where we do health literacy interventions. Right now they're mostly targeted at adults, and this shows a potential need for in the pediatric population as well. Another study found a positive association between low reading levels and adult smokers waiting in pediatric clinics. And this kind of illustrates the broader effects of low health literacy. So just like smoking, it doesn't affect only the individual who smokes or the individual with low health literacy, but it can affect the people around them as well. We're going to do another poll. So if you still have the page up and you just refresh it, it should still be there. If not, you can type in the website again. At what reading level should patient materials be created? Everyone good? Happy with your answer? So great job. So the ideal reading level is about a 5th to 6th grade reading level. So most of you actually said 4. So that's great. So I just wanted to quickly share this table. It was developed by 2 researchers, Mosenthal and Kirsch, to assess document complexity. And they ultimately, out of this, created a document readability formula. What they did was they came up with proficiency levels that they then translated into grade levels, which is what you see in this chart here. So for someone who achieved a 4th grade reading level, it means that they will have done at least 8 years of schooling. Right, for someone who has an 8th grade reading level, it means they have a high school diploma. So you can't just base it on the grade someone completed. So if your patient tells you that they have a GED or they graduated from high school, it doesn't mean that they read at a 12th grade level. Does that make sense? So it's not enough for us just to ask our patients, like, what grade did you complete? Because it doesn't translate necessarily into their reading level. Keeping this table in mind, most adults read at an 8th grade reading level. However, 20% of the US adult population reads at or below a 5th grade reading level, which is why 5th to 6th grade is the recommended reading level for health documents. But most healthcare materials are created at a 10th grade reading level. So you can see how that could be problematic. So lastly, before we delve into the development of our OSCE, we just wanted to touch on the existing curricula. So before we did our needs assessment, we wanted to just look at what already exists so as to not reinvent the wheel. So Kriplani, we looked at these 3 curricula, Kriplani, Harper, and Roberts. Kriplani created an OSCE as well in which he used standardized patients, videotaped encounters, but with residents. And again, we wanted to focus on medical students to kind of prepare them for the process heading into residency. And Harper and Roberts both created health literacy workshops and taught techniques such as teach back, which we employed as well. And we were able to incorporate components of these into our curriculum. And Dana's going to touch on how we developed our curriculum.
So We decided to do a targeted needs assessment at our school, Icahn School of Medicine, 2 years ago in order to determine what our health literacy curriculum had existing and what we might need. So previously in first and second year, general communication skills were taught in ASM 1 and 2. So repeating key information, avoiding jargon, summarizing. And students had the optional activity to do a health literacy activity related to their patient in the longitudinal clinical experience. During years 3, John Giftos in 2012 developed a workshop to introduce med students prior to their medicine rotation to health literacy and its effect on health outcomes. And in year 4, there was an interactive workshop that included student-student role play and facilitated group discussion to further delve into what health literacy is, how to assess health literacy, and how to communicate with patients at any level of health literacy. However, we saw that there was actually no mechanism in place for the students to practice these skills that they were acquiring over the years and to get feedback on their performance. And there was no evaluation of our own curriculum itself. Beyond Mount Sinai, so looking at the curricula that Ariana talked about, none of them actually focused on the hospital discharge period or any transitions of care. As we talked about previously, this is especially a high-risk time period for any patient, especially patients with limited health literacy. And over 80% of the health literacy learning opportunities at other med schools occur during year 1 and 2, with less than 15% occurring year 4, but year 4 students are about to be interns, discharging over sometimes 5 patients a day. And these high-risk time periods are the most important for these patients. And so we really thought the 4th-year students were the perfect population to target in terms of teaching them the skills to discharge patients appropriately and safely. So with that in mind, we adapted our curriculum. So we had the workshop in place during the 4th-year Intro to Internship Clerkship, and then we added an OSCE to assess the application of these skills during the hospital discharge period specifically. So why OSCE? So going back to, Kirkpatrick made a training evaluation for training programs. So level 1 of his evaluation is basically how students perceive the training program to be, so the reaction of the students. Level 2 is learning, so the actual acquisition of knowledge and skills. And level 3 is behavior, so taking those knowledge and skills, applying it to a real-life setting. And that's where we wanted to target. We wanted a level 3 simulation for our students to go beyond just learning them and now applying them. And level 4 is the results in the actual real-life setting, so hopefully in this case, safer discharges, more better transitions of care. So our overall goal was to provide 4th-year students with the critical knowledge and skills to evaluate and communicate with patients with low health literacy, and then to assess these skills using an OSCE station. So we first implemented the OSCE last year during the Intro to Internship Clerkship. There was 128 4th-year students last year. 27 were on interviews or were sick during their OSCE scheduled time. And actually, due to clerkship scheduling, about half of the 100 students received the OSCE workshop prior to the OSCE, and then the other half had the OSCE before the workshop, so kind of providing a natural control group for us to look at. Looking more into the student group, so group 1 is the students who received the workshop, then the OSCE, and group 2, the OSCE, then the workshop. There's about an even split of male-female, and slightly more students going to a primary care specialty in the group that received the workshop first. We define primary care in this instance to be family medicine, internal medicine, or pediatrics. So the Co-Leaders of Space and I last year started from scratch with the implementation. We had a grant from the Gold Foundation, and we started writing out the back of the door instructions, going through sample scripts of a high-performing, middle-performing, low-performing student, really just having fun with it, but also learning along the way. We videotaped ourselves being each one of these types of students, got input from our mentors, Dr. Karani and Galliato, and then once we were ready, we piloted with 4 scholarly year students who had finished their core clerkships of 3rd year, and thus we're in a good position to see how it would be simulated with real-life students. We used the pilot data to clarify the instructions, to edit the length, and improve the consistency of the standardized patients. So more on the last point, one of the key skills we taught in the workshop is putting the burden on yourself. So if a patient has the wrong dosage, after you just explained it to them, you say, I must have not explained that clearly, as opposed to, you didn't understand what I just said. And we realized that 2 of our 4 students actually were perfect throughout the entire practice. And when students are perfect, when they're practicing, there's never a time to put the burden on yourself because there is no misunderstanding on the SP's case. So we decided from that the SP had to have a misunderstanding no matter what level the student was performing at. And so we had all SPs at that point put in a standardized line. I don't know what dose I'm going to take. I don't get it, or something of that sort. For the SP training itself, we ran that as well. We actually showed them the same workshop that the fourth-year students were receiving. The SPs had no idea which students were going to receive the workshop first or after the OSCE. We then showed them supplemental videos of patients interacting with the healthcare system, such as one of the videos Ariana showed earlier. We rehearsed the script a lot. They gave us really important feedback on the script and ways to standardize our checklist. And then we did some role play to practice it. The actual OSCE scenario was 30 minutes total, so a standardized patient case, an oral case, and then a written task. And it has some moon music to it. For the patient case, it was a 60. I don't know where that came from. Yeah, it was exciting. Yeah. Oh, even more exciting. I can describe the patient case. So basically, it was a 67-year-old woman. So she had hip surgery a few weeks ago. She went home, was in bed a lot. She had hemoptysis, came into the hospital a few days ago, found to have a PE. Now that you're told you are the intern, she's been bridged from heparin to warfarin, send her home, explain to her her diagnosis, assess her level of health literacy, tell her she needs to be managed with warfarin, and have INR monitoring. So lots of different scenarios, and we thought this case was especially appropriate for a couple of reasons. One, most fourth years know about PEs, warfarin. It's not something you would study in terms of medical knowledge at this point, so we really wanted to test the health literacy skills. And two, it's a pretty typical scenario of a case that, although it seems simple on paper, has a lot of complicated follow-up appointments and ways that the discharge can be unsafely managed. And for the written exercise, we just asked students to write discharge instructions appropriate for your patient, so ideally the 5th to 6th grade leading level. As we talked about, the students who received the workshop before knew that was the ideal target. And the co-leaders also developed a 17-item checklist based on core competencies in health literacy and previous OSCE checklists. So some of the things we measured included health literacy screening. So for that, for example, the most validated question is, how confident are you in filling out medical forms by yourself? So whether students were using that to assess the level of health literacy of their patients rather than, for instance, what grade level did you obtain? Use of plain language, delivery of a focused message, teach back. So can you show me how? Or if you were to tell a friend what I just told you, what would you say? And general communication skills that are taught in ASM 1 and 2 were again tested in our OSCE as well. For feedback, each student saw their checklist with their score and were asked to complete an anonymous survey, just evaluating the OSCE and workshop for our own sake of knowing how we were doing. In terms of evaluation, the mean score on the checklist itself was a 14.4 out of 17. Students who received the workshop before did do better. So the median score was 15.1 versus 13.4, which is a significant difference. And since the first group had slightly more primary care students, we controlled for that and saw that the significance remains there. Looking more specifically into what the students who received the workshop were doing better at, so over half asked the validated screening question to assess for health literacy versus only 9% who received the workshop after the OSCE. Students who received the workshop first were also more likely to use teachback, normalize teachback, and put the burden on him or herself. But across the entire group, both students were avoiding jargon, using plain language, speaking slowly, and communicating clearly. So really we're seeing that ASM 1 and 2 skills are taught appropriately throughout all 4 years, but that the health literacy, good job, but the health literacy specific communication skills really were being acquired during that workshop. And then we evaluated the discharge instructions with 3 tools as per the health literacy advisory, the Flesch-Kincaid, the SMOG, and the gutting fog. So in all 3 of them, they use word complexity as a polysyllables more than 3 words as a measure of semantic or meaning difficulty, and then sentence length as a measure of syntactic difficulty. And actually the easiest one to use is in the real life setting is the SMOG despite its formula. So if you take 30 sentences, 10 from the beginning, middle, and you times that by the number of words with more than 3 syllables, take the square root of that and add 3, you pretty much will get the grade reading level. And it's pretty easy actually to do, so you can try it on one of the patient instructions you're sending home to your patient. So just a question, how much faith do we have in our Sinai students? What reading level do you think, on average, they wrote their discharge instructions at? So both groups were included in this.
Those are tools on Microsoft Office.
Yeah, so the Flesch-Kincaid's on Microsoft Office, so you can easily just highlight everything and press readability level.
Okay. So we had some faith in our students, but no one, I guess, thought that they'd be writing at the level, the 6th grade reading level. And in fact, you guys pretty much guessed correctly. So on average, our students wrote their discharge instructions at the 10th grade reading level, which is actually better than a lot of patient materials, still not quite what we're aiming for. And when we compared the two groups, the students who received the workshop first did in fact perform better on this measure. So they wrote on average at a lower reading level than students who didn't get the workshop. So 9.9 for those who got it, 10.6 for those who didn't, and that difference was significant. And before we move on from the discharge instructions, I just want to give you 2 examples of sort of different reading levels. I think the formula are a little bit complicated to understand exactly what this means. So the first example, this was written at a 6th grade reading level. So what is pulmonary embolism? Lung blockage. Like the pipes in your house, your blood vessels can get clogged. So you can see from this example, the words tend to be shorter. The sentences are shorter. Again, there's still some terminology in here like pulmonary embolism, but that's actually the term that's then being defined. So in the case of these sort of polysyllabic words, we then go on and get a further explanation. Compare that with this example. Side effects that you should look out for include any signs of continuous bleeding, particularly from the gums and in your stool, fever, dizziness, altered mental status, and the list goes on. And it's not that that's not medically correct. In fact, I was reading this and thinking that's probably more side effects than I would have been able to come up with in the moment of writing these discharge instructions on the OSCE. It is all correct, as is the first one, but the sentence is a little bit more complicated. The word length on average tends to be a little bit longer, and there's a lot of information in there. And so this, again, the 12th grade reading level is beyond what we would want to give patients and probably might be more information than someone would be able to absorb in the setting of a hospital discharge. Moving on to the survey results, as Dana mentioned, we not only gave our students feedback on how they performed on the OSCE, but then asked them to tell us what they thought about the experience and how confident they felt either after getting the workshop or getting the workshop and the OSCE. And we found that 87% of our students said they agreed or strongly agreed with the sentence that they felt confident in assessing a patient's health literacy level. 82% of them said that they, again, agreed or strongly agreed that they could effectively communicate with patients with limited health literacy. And as all of you who work in medical education would be pleased to know about your graduating students, 97% said they thought health literacy was important to consider in patient care. And I would certainly hope that that number would have been as high as we found it was. So to summarize what we've done, we created and implemented this health literacy curriculum and skills-based assessment for 4th-year medical students. Our curriculum focused not only on imparting communication techniques that students have been learning throughout their 4 years of medical school, but really thinking about how to apply those techniques in the setting of optimizing safe transitions of care at the time of hospital discharge. And we found that this was something that we could feasibly implement at our institution. And in fact, while this was piloted last year, we've actually been able to continue the OSCE and workshop this year through the support of the department, which is really wonderful. And I think, what we were really in a fortunate position starting at Sinai, because we already have the Morshan Center. We have OSCEs that are already integrated in the curriculum at other points. So on the student side, students kind of knew what to expect going into an OSCE. This is something they were familiar with. And on the faculty implementation side, it wasn't something that we had to introduce as a new idea. So we feel like great that we implemented it, but a lot of it came from what was already existing at Sinai. And the fact that there was this 4th-year clerkship that students already were required to do, so there was sort of a natural point to target students before starting internship. Well, we're happy with what we did, and we did find that students did better with this workshop, both on terms of the checklist and the readability of their discharge instructions. There's, of course, always more that we could do. So I just want to go. I think we lost a slide. So the strengths of what we did, the workshop and OSCE that we used, we sort of, as Ariana and Dana were explaining, we used prior curricula to build what we were doing on that. We didn't want to reinvent the wheel.
But we also knew that there was this idea of sort of focusing on fourth-year medical students, focusing on transitions of care, and that really was novel. We didn't see that elsewhere in the medical education literature. This wasn't a time that most educators were focusing on in terms of the students. And that, I think, for us was a really important part, because not only are patients in a vulnerable period during transitions of care, but fourth-year students, the first time they're thinking about managing patients on their own, they're in a new position too. And preparing soon-to-be interns with tasks that they're going to have to be doing multiple times a day, and giving them, the skills, reiterating some skills that have already been taught, but also giving them some new skills to think about how to do that, we felt was something that made our curriculum pretty novel. Again, there's always things we could be doing. So one thing that we thought about doing is assessing skill retention over time. So there's the question, of course, if you give someone a workshop, you survey them on something or have them practice something they learned in a workshop 1 week prior, does that knowledge persist over time? This would be a little bit hard for us to measure because, again, we're working with fourth-year medical students prior to graduation, so that might require trying to contact potential interns at the start of their internship. That might not be the easiest thing, but we could think about for students who got this OSCE kind of maybe the beginning of the second semester of fourth year, could we measure this on later clerkships in fourth year and see if they're actually taking these health literacy skills and remembering them. And then related to that, do these skills that we've seen students do in the OSCE, do those actually happen on the wards? There's been a lot of literature written about how well OSCE simulate real patient encounters, and sort of can you assume that someone who's performing these skills in an OSCE then applies them into the real world. And there's a little bit of mixed results on that, so it would be interesting for us to sort of see our students asking the validated questionnaires on the words, are they using teachback in real life? The other question would be maybe doing some sort of potential for self-assessment and debrief. So the way we have used the OSCE right now is primarily as a way of assessing the workshop. So we're sort of going up the Kirkpatrick model, we're teaching someone something, the skills, then seeing if they're doing the behaviors. But we could, in fact, use the OSCE as a teaching tool in of itself. So not just as a means of evaluation, but then to sit down with students instead of just sort of saying, here's your checklist, this is the feedback you got, actually going through it with students, taking that time to sort of do teach back and have them kind of relearn any areas that they might not have felt they learned the first time. And I think that, compared with our first two potential future efforts, feels a little bit more feasible and is something we're going to try to do in the future. And then the last question, I mean, we've had wonderful space leaders of year past. We've done a lot of development of various workshops and lectures across the years, but sort of thinking about, are we integrating these? Are we teaching students in a way that's sort of stage appropriate? So what you would be teaching a first-year medical student might be different than a fourth-year medical student. And my favorite example of this, so this year, we created a health literacy small group for In Focus Week, which is one of the new curricular efforts among the all 4 years of medical school to bring students together, sort of teach the non-scientific skills. I'm sure you guys are all very familiar with this. But what we did as part of In Focus is develop a health literacy group just to make people sort of aware and thinking about barriers to health literacy. And so one of the skills that we tried to teach in this group was being specific when you're giving instructions around medication use. So not just saying, take this medication twice a day, but maybe saying, take it with breakfast and dinner, or take it at 8 a.m. and 8 p.m. So we were doing a role play with the first years, and one of them was trying to use this skill and then said to our group, I was sitting with Dr. Rip, two students doing the role play, and he advises his fake patient, take your metformin in the morning with a glass of orange juice. And the two of us just look at each other and we're like, how do we respond to that? We don't want to be giving this diabetic patient more sugar. But I think that really highlights for us the fact that we can sort of be teaching these skills alongside medical knowledge, and that there's still things that you can be teaching first-year medical students before they've acquired the clinical knowledge, but that what you'd be teaching someone once they actually know what metformin is, when it's used, might be a little bit different. And so we really have tried over this year, and will continue to do so, to make sure that at each stage of the curriculum, what we're teaching is sort of appropriate for the relevant medical knowledge, and that those skills build over time. So we're going to continue to be running this health literacy small group during the In Focus Week, again thinking more broadly about barriers to communication, less about specifics of a discharge instruction. We've built on that. We also this year designed a 2-week curriculum in ASM 2. Again, students at this point have a little bit more medical knowledge, so we sort of moved a little bit further, not just thinking about barriers to health literacy, but how could you actually assess a patient's health literacy in the clinical setting. In the third-year clerkship, we continue to reiterate the idea of screening, but at this point, also moving towards educating patients in a way that's mindful of their literacy level. And then finally, in 4th year, the workshop in OSCE, which is focused not so much on barriers to health literacy or sort of starting to get students to think about this, but really how do you apply knowledge and awareness and those skills and the questions that we've been teaching all along to actually educating patients in a way that optimizes their safe transitions of care. So we just want to thank all of the past space leadership teams. I think Dr. Bedard is here with us today, one of the founders of SPACE. We're really grateful for everything that the past leaders have done along the way. It's made it much easier for us to sort of implement these new things and build on what they've done. Dr. Gliado and Dr. Karani have also been wonderful in guiding us as we start to develop these different workshops and lectures. And as I mentioned before, without the support of the Medical Education Department and the Morshan Center, it would have been tremendously harder to implement an OSCE and the workshop that we did, and we're very grateful for that support as well. And as well as I said before, the intro to internship team, because again, having this 4th year clerkship and having the flexibility that they've allowed us to just take random mornings and put OSCEs in them has been very, very helpful. So with that, what questions do you have for us?